the leg aren't getting better, they're atypical, they have night pain, you have to think about tumors. Probably the other thing, at least with my athletes, is you have to be holistic, you have to be complete. So you have to look for all of these associated potential factors that are contributing to their leg pain. In the morning talk, somebody talked about the passport for your athletes. What is their baseline before they started having this injury? How much had they been training? How much had they been running? What's their alignment? What's their gait mechanics? What's their shoe wear? What's the surface that they're running on? All of these things are going to play a key role that perhaps if you address the underlying source, then you don't have to be worried about surgeries and other things that some orthopedic surgeon is going to be talking to you about, because you've addressed that underlying thing first. Age plays a role, gender, we talked a little bit about between in the military things can play a role. BMI, overweight people tend to have a higher risk of leg pain. What's going wrong with it? So the other thing that I strongly suggest is you look for the potential of overlapping diagnoses. So generally, everybody knows what Occam's razor is? Occam's razor. The most likely diagnosis, if you narrow things into one thing, it's the most likely. If you can narrow things into one answer, it's most likely true. So if you have to explain things with 5 different things, it's probably not true. If you can put it all in one box, one nice explanation, it's probably true. So that's probably true with leg pain also, except that sometimes you have these overlapping diagnoses. I've had a couple of patients who had stress injuries to the bone, had borderline compartment syndrome. They had a stress injury to the bone, caused swelling into the compartment, and now had exertional compartment syndrome. So really, they actually, if I treated the underlying problem, which is the stress injury, their borderline compartment syndrome went away. And so understanding that these things can overlap are going to be important. So you have to look for those different things. Now, key clues I'm going to look for in terms of leg pain. Pain with first impact. I hurt when I just step down, or I just have them land on their heels when they jump. That's a stress injury of the bone until proven otherwise. Medial tibial bone pain, or on the medial, posterior medial border, medial tibial stress syndrome. Generally that's broader. So if you can cover that area of pain on the bone with one thumb, that's a stress injury or stress fracture of the bone. If you can't, it's really broad, then that's probably medial tibial stress injury. If it's focal muscle pain, strain or muscle hernia, focal tendon pain, clearly tendinopathy. If they have pain with vibration, anybody still carry their tuning forks? Anybody do ultrasound? If you still do ultrasound or use your tuning forks, stress injuries of the bone oftentimes have increased pain with vibration. So if you ever have that, that's probably true. The other thing we said, probably the key issues, is pain with impact. That's a stress injury of the bone. Pain with exertion. I had no pain at all, rest at all. Pain with exertion, that's exertional compartment syndrome, or potentially popliteal artery entrapment syndrome until proven otherwise. So if you're at rest, no, exertion, something's going on. And then you look at the other different things. Pain at night, burning pain, or should give you other clues. Motor weakness, think about herniated discs, muscle weakness, paresthesias at rest, nerve entrapment, herniated disc, paresthesias with exertion. You think about exertional compartment syndrome again. If they have diffuse swelling, I start looking for weirder things. If it's a swelling with exertion, it's exertional compartment syndrome. If there's diffuse swelling, I worry about DVTs, atherosclerosis, and then some other things. Muscle cramping, muscle strains, vascular claudication, other different things could potentially contribute. Now let's talk about a couple of the key things in terms of leg pain in athletes. So, compartment syndrome. One thing you never want to miss is an acute compartment syndrome. It's a little bit different than exertional compartment syndrome. Exertional compartment syndrome, sitting around doing nothing, no pain at all. They go run, and I'm going to tell you, 5-10 minutes into my run, I started getting pain where generally the anterior lateral aspect of their leg, that's what hurts the most, less commonly deep. And when they stop, it goes away. That's exertional compartment syndrome. How about acute compartment syndrome? This problem gets worse. It never relaxes, it never goes away. Usually associated with trauma. But one lesson for our athletes that you need to know is that sometimes exertional compartment syndrome can convert to an acute compartment syndrome. Be really careful of that. I've had a few different hikers. I've had distance runners who said, oh yeah, I get that pain. I had shin splints. It happens occasionally. but this one I just ran through it. My leg pain never went away. Well, they may have converted themselves into acute compartment syndrome, which is a surgical emergency. So you got your 4 compartments of them. Most commonly is going to be anterior and lateral compartments, and that's generally what you can look for. Look for tension, look for pain with exertion, look for it to go away. The deep compartment, less common in terms of its location. How do you make the diagnosis of exertional compartment syndrome? I just told you how to make it by history. How do you prove it? You do pressure measurements. So this is Rob Pedowitz's classic thing, almost 27 years ago, still used. However, interestingly, the actual numbers and how you test it are a little debated in the international literature. So is it really 0 to 10 is normal, 0 to 20 is normal? For me, if my athletes begin over 25 to 30, that's suspicious. And then with exertion, it needs to jump up more than 10. Those are the criteria that I look for to make the diagnosis. Is it absolutely valid and reproducible? It's actually pretty good. The thing is although the international community has debated it, it's still pretty much the best we have. It's hard to do continuous measurements in these athletes. So one thing is, don't be afraid to do the test. Striker monitors are pretty easy to do. You just poke into the compartments, numb it up first, and your patients will be happier with you. And then go run them until it hurts. I run them 5 minutes until it hurts. Come back and retest. People have talked about the most common compartments were which ones? Anterior and lateral. So some people have suggested that's the only ones you need to test. I test all 4 compartments in every patient, both sides, because I didn't ever want to come back and have this test again. You can kind of see why. There's been some suggestion that maybe we should do continuous measurements, put a slip catheter in, and then measure them continuously. The problem with this, with doing it continuously, is sometimes the catheter comes out. You do get a different measurements and stuff like that. It's harder to do. It's just easier to do this single measurement. Some people have suggested non-invasive testing. Nice idea. Basically, you know, the little pulse ox machines you put on all your patients, you check their oxygen. It's infrared spectroscopy which does that. Well, you can do that over the leg too to assess oxygenation. And it's been shown to be 75 to 80% success sensitive. Nice choice. The problem is, really expensive little machine that you're supposed to have in every one of your offices. And by the way, it says Hutchinson Technologies, which isn't me. I actually went to this company and said, could you please give me some of these so I could practice and see how really effective it is? And they wouldn't even give me one. So you can see I don't sell their product. So ultimately, the treatment for exertional compartment syndrome classically has been surgery. So if you've proven positive, you don't have those associated injuries, what's the most successful thing? Surgical release of the fascia. However, in 2013, a couple of other people wrote a couple of other articles about switching them from heel-toe running to just toe running, or using botulinum toxins to potentially ease their pain. These are the studies for evidence for toe running. And it's kind of interesting because they're all very positive effect by converting them to toe runners. However, the quality of evidence here is all level 4 evidence. They're all small case series. We haven't really proven this out over the long term yet. My personal concern is changing somebody from a heel-toe run to toe run may help with exertional compartment syndrome, but then they're going to get overuse injuries in their forefoot. But so interesting, I think. How about Botox? Actually works. If you actually paralyze the muscles in the leg, they don't get tight, doesn't build up the pressure. The problem is they also get weak. And so for our athletic population, while it is effective, it's probably not a good idea. Surgical releases have been the way to go. We wrote a study in 2013 that says if you do a fascial release, that's about 70 to 80% of the length of the fascia, it's successful. And that's true. What are the actual outcomes? Surgical outcomes, not bad. If you look at this Packer study, they look back and look at a variety of studies, at 100% success rate was the anterior compartment. Lyle McKaylee suggested a little less successful in females. I know Lyle is actually one of my academic grandfathers, and actually I don't know if that's actually true. I think that you have to be very careful about the associated factors. If you rule out the associated factors, my outcomes in women are the same as the men. But I think you got to look at those things. And then if you do posterior releases, they don't do as well. Here's another problem though. There's several military studies that says in the military they don't do quite as well. 78% in the military in terms of pain-free, but actually only 28% were able to return to full duty, and 45% said that they still had incomplete relief of the symptoms. Why is that so bad? Again, I believe it's because either a misdiagnosis, missed associated injuries, or that loading phenomena that led to it in the first place. I think if you address those things, they should be able to have the same success rates. And my personal success rates, over 400 endoscopic assisted releases, 90% successful. It's a few minor complications, but pretty good surgery. How about muscle herniations? Muscle herniations can occur. You basically see a little bit of a little focal swelling in the leg. You can actually prove it with an ultrasound and visualize it pretty nicely. There you can see faster layer, some stuff pushing through. What's the ultimate treatment if you have a muscle herniation? These are probably associated with exertional compartment syndrome. So people have tried to sew them back together, not so hot. Just complete the release like you do a fascial release, very successful. Popliteal artery entrapment syndrome, this is the confusing one. This is actually where they say I have exertional pain in the deep aspect of my calf. So this is that, so not anterolateral, not classic. First thing I think about is popliteal artery entrapment syndrome. What's going on? Well, what happens is you can have a little fascial band where the artery pierces between the gastroc muscles, or you can have variations of the anatomy of the artery. So sometimes it's really kind of weird. Usually it should go between the gastroc muscles. Here you can see one going around the medial gastroc, all the way around. So there's a variety of variations there, but what happens is these athletes start to train, and they cut off their own circulation because it pinches on the artery.
Now, slowly press down on your foot.
And I don't really need the volume, but that's okay. Let's see. And what I like to do is,
slowly press
here you
down.
can look,
Now let it relax.
and you can see the artery completely wash out and disappear just with the venous complex.
Slowly press.
Ultimate treatment or ultimate diagnosis, MRA, arteriography helps make the diagnosis. In terms of the actual outcomes for popliteal artery entrapment syndrome, if you can identify an anatomic variant or a fascial band, success rate's 90% in terms of surgically releasing that. So very successful if you can find that. If you don't do that, it's just functional decrease, but you don't see an anatomic variant, the success rate drops to about 77%. Again, they use Botox in this area with some success. Stress fractures, the other common area in terms of our athletes, commonly associated with military recruits, 1 to 5% of athletic-related injuries, 1 to 25% of exercise-related leg pain. Most common stress fracture in the tibia, certainly can get them in the feet. The things that you really want to pay attention to is if they've got a little bit of a radiolucent line in the post-tibial aspect, that's a good sign, they tend to heal. Anterior radiolucent line, anterior awful, those are the ones that tend not to heal. I have one of those in one of our star basketball players right now, and it just scares us to death whether he's going to be back next year playing or not. What do we do for him?
1 minute.
Pardon? 1 minute. We decrease. We put leg braces around his leg. Therapeutic ultrasound, bone stimulation to try to reduce his stresses, and he's actually responded quite nicely. So here, in terms of some other things to consider, certainly with the females and stress fractures, always consider most common presentation for an orthopedic surgeon of a stress injury. Think about the female athlete triad. In terms of those treatments, knee-high air stirrups, particularly like them, but not this one. You got to get them all the way up the leg so it actually bridges the stress fracture for potentially. And actually, there's been no case ever that's actually shown a fracture all the way through if they actually trained and felt reduced pain while using a knee-high air stirrup. Because this is what you don't want to see, fracture all the way through. So alternative treatments, if they're particularly resistant, then you can put a rod down. Last thing we'll talk about, we talked about exertional compartment syndrome, stress fractures, the broad differential diagnosis, medial tibial stress syndrome. This is the pain may be associated with flat feet, pain over the medial aspect of the leg. Pathophysiology, not particularly clear. Currently think it's a diffuse stress injury of the bone. Treatment is going to be basically similar to stress fractures. I use a knee-high air strip, similar types of causative responses. So somebody was suggesting that I should be done. Actually, I'm almost done. DVT, be really careful of DVTs, particularly in travelers, females on oral contraceptives. Vascular claudications, that older population, look for those associated potential other things. So vascular claudication, pain. Interestingly, these older patients actually respond quite nicely to lipid control. Plan of attack, broad differential diagnosis. Look for all kinds of other laboratory things for crazy things, x-rays, MRIs, CTs. This is just things, this is on your handouts and things like that in terms of other things to look for. We'll skip back to Dominique. So avoid thinking anatomically. Common things are common. Beware overlapping diagnoses. Consider all the different contributing factors. Target the most likely diagnosis. Don't be afraid to compartment test. Always screen first-time stress injuries in female athletes for the female athlete triad. Use the best evidence available and use a team approach. Thank you.